Assalamu alaikum, everybody. Welcome to MDI's Active Living Seminar. My name is Dr. Abdul Rahman, and I'm very delighted to present to you a very capable and young person who Calgary has been discovering recently, Liaqat Ali Khan. He is a master's in sports medicine from Sweden, and he has also been working in the past with the Pakistan Cricket Board. So we are fortunate to have him, and he's going to talk about the need for us to ensure that we are looking after our shoulder, how to make our shoulders strong. So he is going to talk about that. He will present some images, some information that will be very useful for us. This event is going live and is on the Facebook right now, and hopefully other people will be able to benefit from his presence. Welcome, Liaqat Ali Khan Sahab. Good to see you here. Take it over and please help us understand these little bit about sports medicine and our shoulders.
Sure.
Strong shoulders to carry the weight of our life. So
Yes.
over to you.
Okay, Dr. Sab,
Yes, sir.
should I proceed?
Yes, of course. Please go
Okay,
ahead.
assalamu alaikum, everyone. As Dr. Sab introduced me, I'm very pleased to be in front of you all. My name is Liaqat Ali Khan, and I'm a physiotherapist. I work as a physiotherapist since 2003. I graduated from Pakistan, from Karachi first, and then I went to Sweden to do my master in sports medicine. In the meantime, I work in different hospitals, and I work with mentally and physically challenged children as well. And then I started working with the Pakistan Cricket Board. I worked there for about 8 years, and then I moved to Canada for a better career, I believe. So now I am in front of you, and right now I'm working as one of the physiotherapists at Genesis Group of Physiotherapy Clinics, which Ramesh owns, the guy who presented the last time. So today we will be talking about the shoulder, how to keep our shoulders strong and pain-free to carry the burden of life, as Dr. Sab said. I would like to share my screen with you guys, which I tried my best to prepare a presentation. Dr. Sab, are you able to see my screen now?
Yes, we are able to see. Yeah.
Okay. So I'll start with a brief introduction to the anatomy of the shoulder joint. As you can see that the shoulder joint is made of a few bones, in particular to the scapula and the humerus, and it articulates with the glenoid cavity of the scapula, which is deepened by a labrum because the head of the humerus is bigger than the glenoid cavity. And then if you look at this, here is the clavicle, which is articulated with the sternum, the chest, and then the clavicle is articulated with the scapula here as well. So it's forming two joints here. One is the sternoclavicular, one is the acromioclavicular. These are very important joints. We will be discussing it not in very detail, but briefly. And then the scapula, it forms an articulation with the trunk as well, which we call the scapulothoracic joint. It's not a true joint, but technically it is an articulation with the trunk with the muscles, and that's very important as well. Then the shoulder joint is composed of some structures that stabilize the shoulder joint, which are we call the static stabilizers, and then the dynamic stabilizers. The static stabilizers of the joint are the capsule and the ligaments, different ligaments that hold the joint in place. Another structure is a bursa, which is a very important structure as well, that lies on top of the supraspinatus muscle and beneath the acromion process, or this space that covers this space, and it helps with smooth movements of the shoulder joint. When we talk about the stabilizers, as I just mentioned, so we have the static and the dynamic stabilizer. There are two kinds of muscles that are affecting on our shoulder joint. One is the extrinsic muscles. I don't know who is. Just give me a moment. Someone is knocking at the window. Just give me a moment, please. I'm busy in a. You want me to open the door? Okay. Please excuse me for a moment. Someone is at the door. I will be back soon.
Dr. Zahid, welcome. Thank you for introducing Liaqat for this particular session. It's good to see him. He's a young man who is recent to Canada.
Sorry, Dr. Sab. Sorry, Dr. Sab. It's actually not the clinic open time, but I think someone from the repair guys was banging the window, and I had to open the door for them. I'm not sure what time. So
No
let's
problem.
continue, Dr. Sab. So we were talking about the muscles. Two kind of muscles are there affecting the shoulder joints. One we call the extrinsic muscles, which comes from the backside. You can see the trapezius, the latissimus dorsi, the rhomboid minor and major. They are holding on to the joint from the backside, and then from the front side, the pectoralis major minor, the deltoid, the scalenes, and the serratus anterior. They are affecting on the joint from the front side. When we talk about the intrinsic muscles, these are the four muscles which we call the rotator cuff muscles as well, and they are holding actually the humerus inside the joint or inside the capsule. When we are moving the arm up and down or in any direction, they keep the the joint integrity, or they keep the humerus in its place. So these are four muscles. These are the supraspinatus, the infraspinatus, and at the front there is the subscapularis and the teres minor muscle. We already have talked about the the static and dynamic stabilizers. We will touch the biomechanics briefly. We will not go into details. So when we are in resting position, when the arm is hanging in rest, the glenohumeral joint capsule is relatively lax. It's unusual thing compared to the other joints where the capsule gives lots of stability to the joint. But in the glenohumeral joint, it's relatively lax. It does provide some stability along with the coracohumeral ligament. But once we start elevating the arm, then the rotator cuff muscles take over and they contract and hold the humerus in its proper orientation with respect to the glenoid cavity. So we will be talking about the posture again and again. One of the reasons for the posture is here. In persons with the kyphosis, the scapula follows the contour of the thorax and it assumes a downward rotated position. If the rotator muscles, so to keep it aligned, the rotator cuff muscle must contract to maintain the joint integrity with the arm at side. But once the rotator cuff muscles, if they are on a continuously acting, the tone of the rotator muscles increases. And once the tone is increased, that increases the stresses on the joint capsule. When the stress is increased on the joint capsule, it increases the collagen production, and that eventually leads to the frozen shoulder. We will talk about the frozen shoulder a little bit later. So when we are moving our joint, it's not only the glenohumeral joint that's moving, but apart from the glenohumeral joint, there are multiple joints For example, the acromioclavicular, the sternoclavicular, the scapulothoracic articulation, and along with them, the lower cervical and the upper thoracic spine. It also contributes in the normal mobility of the shoulder joint. We will take one example of the abduction. So when we move our arm on the side, that is abduction, the first 15 to 30 degrees of the abduction that usually happens on the glenohumeral joint. During this, the muscle of the scapula needs to contract to prepare the subsequent movement. So if there is any weakness in the scapular stabilizers, we will not be able to move the arm normally. Once the arm moves past 30 degrees, so the 15 to 30 degrees abduction, the humerus continues to elevate with respect to the scapula. The scapula also moves with the humerus. So it moves in a ratio of 1:2. Like if the humerus moves 10 degrees, the scapula normally should move 5 degrees as well, to give us the normal scapulohumeral rhythm. The combined glenohumeral and scapular movement that gives us about 160 degrees of full range of abduction. But after that, the remaining movement occurs as a result of the lower cervical and the upper thoracic spine. When we elevate both our arms simultaneously, if the extension does not happen in these two regions, like the cervical and the thoracic region, we will not be able to elevate our arms up. So again, the posture comes here. If we have a kyphotic posture, we will not be able to gain the full 180 degrees of the arm's elevation. So the posture is very important. Good posture is very important for the shoulder. What leads us to see the doctor, or what are the things that we should consider that if we have a shoulder injury or not? So we should ask ourselves a few questions that will decide whether we have a shoulder injury. The first question is, are you able to move your arm normally, or is the shoulder stiff or painful? Do you feel like your shoulder could pop out of the socket? That's the dislocation. Is your shoulder strong enough for the things you normally do? Are you able to do your things normally as you usually do? So some of the things that regarding the shoulder injury we can treat at home with some rest and some ice, but usually the professional help is required, right? So when you should see a doctor, if your shoulder joint looks deformed, if you think that the shoulder joint is not as normal it should be, or if the shape is altered, you should go and see a doctor or physiotherapist right away. If you are unable to use your shoulder at all, you should go and see a doctor. If the pain is intense, so usually intense pain is not a good thing for the shoulder. So you should go and see the doctor. If you see that your shoulder is getting swollen suddenly, and if you feel any numbness or any weakness in your arm, you definitely need to see someone for the help. There are multiple causes of the shoulder pain. For example, an accident or an injury or a fall could cause you any the shoulder pain. Many sports or many athletes, they get the shoulders injury, overuse like painting or any overuse. In our community, one thing that I noticed was that from back home when we come, usually we do not do repetitive lifting back home like some people are engineers, doctors, and people like that. So when they come to Canada and they start doing the odd jobs, and their job includes the repetitive lifting and the stuff like that, they usually go through this shoulder injury, which is not a very good thing. But we at some points we feel that repetitive lifting or the activities that cause us the shoulder injury, and that's why I picked up the, the topic that we need strong shoulders to carry our burden. Another reason could for the pain could be the arthritis. Uh, Sometimes the pain is not because of the injury inside the shoulder, but it comes from some other part of the body. For example, um, the cervical spine or the neck, when there is compression of the nerves that refers the pain to the shoulder, or sometimes irritation of the diaphragm or the kidney, liver, or the heart that could cause the refer pain in the shoulder as well. Um, so some factors that cause the shoulder pathology or the shoulder pain. One of the most important thing is the rotator cuff pathology. As we already discussed, there are four muscles of the rotator cuff: the supra, infra, spinatus, the subscapularis, and the teres minor. They arise from the scapula and they are attached at the humerus. So the rotator cuff pathology, it includes the tendinitis, it could be bursitis, it could be an impingement syndrome, or it could be a partial or a full thickness tear as well. Again, overuse is an important factor in most of the cases for the rotator cuff injuries. One of the commonest thing in the shoulder injuries or the rotator cuff is the tendinitis. It affects the young as well as the older persons, and it equally affects the woman and the men. So this is a very common thing for the shoulder. In young person, it may be caused by activities such as the tennis or the racquetball or the baseball. In older person, it is more likely to be degenerative lesion because of the poor blood supply near the insertion of the supraspinatus. Nutrition is affected, like the tendon may not get proper nutrition because of the low blood supply, and that results in the degeneration of the tendon, and that results in the weakening as well later on. And sometimes the pain recurs or the weakening happens in the rotator cuff muscles, and one of the factors for that is the reflex inhibition, or it might be the disuse that we do not use our muscles or we do not do the strengthening exercises, and that is one of the causes for the recurrence or the weakness of the shoulder muscles. And if we have weakness in the rotator cuff muscles or the shoulder joint muscles, that results in the subacromial impingement. So that is like a mechanical cause for the impingement of the shoulder joint. So we need to have strong rotator cuff muscles to prevent this or treat this. And the common impairments that we see because of the rotator cuff injury or the impingement syndrome, there should be pain at the muscular-tendon junction, whichever muscle is involved. And one of the things that may be present is the painful arc or the positive impingement sign, which is when you force the shoulder into the internal rotation at 90 degrees of flexion, and that is painful. Or when there is a painful arc, that is when you elevate or abduct your arm and you start feeling pain at about 70 degrees, and it still is there until about 110 degrees, and after 110 degrees the pain disappears. That is called a painful arc, and that is one of the signs of the rotator cuff or the impingement or the bursitis. Again, the impaired posture is one of the factors that causes us this shoulder injury. When we have the shoulder injury, certain muscles, for example, the muscles at the front, the pectoralis major and minor, or the internal rotators, they get shortened because of that impaired posture. When we have protracted shoulders or kyphotic posture, so the pectoralis major, that pulls the shoulder forward, and that gets shortened or stiff, and as a result, the serratus anterior or the external rotators, they get weakened. The cervical spine and the thoracic spine that we talked about earlier, if they are hypomobile, that is again one of the reasons for the shoulder joint injuries or the rotator cuff muscle injury. If there is a complete tear, we will not be able to abduct the arm against the gravity. And so how we do the assessment, this is for all of us. Usually the active and the passive range of motion is relatively full, but at the end range of the flexion, there we feel some pain and some limitation because the structures are getting pinched between the greater tuberosity and the posterior rim of the glenoid cavity, and that causes the pain at the end range of flexion usually, or abduction. Again, there is the painful arc is usually present in the rotator cuff and impingement syndromes. Interestingly, the resisted movements are very strong, like they are not affected unless and until there is complete rupture of the rotator cuff muscles. Different tests are there to check out what muscle is at fault. Like, for example, we do an empty can to see if the supraspinatus is affected or not, or we do the near impingement test to see if something is getting impinged in there when we perform that. For the management of the rotator cuff muscle, we do the management into acute and subacute or chronic stages. The goals for the rotator cuff, the acute stage should be, the primary thing is the patient education. Whenever we have any injury like the rotator cuff or the impingement, or like in general, the shoulder when it is affected, anything, the environment or any activity that increases the pain, that should be modified. For example, if we are working and the work is lifting something and that is affecting the joint and that is increasing the pain, we should modify the lifting technique or should completely avoid that activity because that's affecting the healing process or that aggravates the symptoms. So we should avoid that. We should take rest from that. The goal for the acute stage should be controlling the inflammation and promoting the healing. So you guys, doctors, they can recommend the anti-inflammatory. I will not talk about the medication, but this is usually I see in my practice that doctors recommend the anti-inflammatory medications. Physiotherapy treatment that consists about of some modalities, for example, ultrasound and another modality that we have in our clinic that gives us a wonderful result in this rotator cuff or the inflammation and promoting the healing is the laser. Or we can do the cross fiber massage as well. There is not much evidence of the low intensity cross fiber massage, but it does help with decreasing the pain and promoting the healing. We should control the pain and the joint integrity. So the exercises, I'll go through the exercises at the end of this presentation. But one of the exercises that helps a lot is the pendular exercises that provide some distraction and decreases the pain as well and maintains the mobility of the shoulder joint. The exercises usually in the acute case, acute stage are the passive range of motion or the active assisted. I'll go through the passive and the active assisted exercises at the end of this presentation. Once the inflammation is under control, then we progress to the strengthening of the muscles or the healing tissues. We usually start our exercises with the isometric exercises. and that leads to the dynamic exercises. But again, every exercise that we do should be pain-free. If anything that causes the pain, we should stop immediately. Another common problem that affects especially our teenagers or our youths is the instability. Instability can happen to anyone. Uh, so there are two types of the instability. One is the instability of the shoulder joint that is caused without any trauma. That's called the atraumatic instability. And that is as a result of the generalized tissue laxity from the micro trauma related to the repetitive activities. Usually we see the atraumatic trauma or the atraumatic instability in our youths who are doing the swimming and the racquetball and the volleyball um, games like that. Another type of the instability is the traumatic, which is caused by either a single or a sequence of high force events that compromise the integrity of the stabilizing structures, leading to dislocation of the shoulder joint. So once the shoulder joint is dislocated, the primary thing we should do is, or the first thing we should do is we should see a doctor, because that is the doctor's job to reduce the dislocated shoulder. But when it's reduced, then again we will need the rehabilitation or the physiotherapy treatment for that. This thing, the instability, this leads to recurrent dislocations, and sometimes um, it affects the players or the athletes a lot. And they describe the feeling of the slipping out of the joint along with the pain as well. And if there is instability in the joint, when the player or the athlete starts playing, that gets obvious when he plays for some time and then he is unable to continue the play, or he needs some kind of taping or some stability for the shoulder joint to continue the game. Um, this instability can be unidirectional, that is in one direction, either anterior, posterior, or inferior, or it could be multidirectional, like it could be at the same time, it could go like into anterior or inferior direction, or anterior posterior is there is a huge laxity that the joint goes anteriorly and posteriorly as well. Because of this instability, if it is accompanied with the rotator cuff rupture, we are unable to reach or lift objects even to the horizontal. The anterior dislocation, as I already mentioned, is it affects the ability in the sports such as the pitching, the swimming, the tennis, the volleyball. So any activity that involves the overhead movement of the arm, that affects that restricts is restricted by the anterior dislocation. Usually the posterior dislocation results in the restricted ability in pushing activities, for example, pushing a heavy door, or pushing oneself from the chair, or getting out of the swimming pool. So whenever we put any pressure on the shoulder joint and that goes posteriorly or backwards, that is because of the posterior instability, and that is accompanied by the pain as well. When it comes to the management, the operator management, that is the doctor's job, but we can try, or we should try, the rehabilitative management as well. And again, the strength of the rotator cuff muscles is very important. So the rotator cuff muscles and the scapular stabilizer muscles, if they are strong, they hold the humerus in its proper position, and that prevents or reduces the instability. On the other side of in contrast to the instability, we have another condition which is very common among the older individuals or the middle-aged individuals, is the frozen shoulder or the adhesive capsulitis. This is the tightening of the shoulder capsule, and It usually affects women more than men, and it usually affects the middle-aged or the older persons than the younger persons. In most patients, there is no specific reason for the shoulder adhesive capsulitis or the frozen shoulder, but there are a few conditions that are associated. So again, the posture comes here again. When the scapulohumeral ligaments, no, not ligaments, but alignment, when that is altered, for example, if someone is having thoracic kyphosis, um, so again, the tone of the what muscles, the rotatory cuff muscles, that is increased, and that causes the fibrosis of the capsule, leading to the frozen shoulder. Another cause could be the degenerative joint disease, which is not very common in the shoulder, but it still could exist. And then the rheumatoid arthritis can be another cause for the adhesive capsulitis, because that affects the synovial membrane and the capsule as well. If someone has got a fracture and his arm is in the sling or in the cast for a prolonged time, that could lead to the fibrosis of the capsule as well, and results in the shoulder, in the frozen shoulder. So the symptoms or the signs of the frozen shoulder are that there's lots of pain. Acutely, the pain and the muscle guarding causes the limitation of the motion, especially the external rotation and the abduction is limited. The pain is, excuse me, the pain is almost all time there, and the pain usually radiates to the elbow as well, and it disturbs the sleep a lot. In the subacute stage, the capsular tightness begins to develop, and it decreases the mobility of the shoulder. Still, the external rotation and the abduction is limited, and in the subacute stage, the pain is not always there, but we feel the pain at the end of the available range of motion. The mobility of the shoulder is decreased, but as long as we have mobility in the shoulder, that's not painful much. But when we reach at the end of the available range of motion, then we feel the pain in the subacute stage. In the chronic stage, pain is not a big concern, but the restriction in the mobility is a bigger concern, because we lose our functional mobility a lot. For example, we are unable to comb the hair or reach into the back pocket even. That's the shoulder mobility is that much restricted. We manage the frozen shoulder if it's the acute phase. Our primary goal is to relieve the pain and the muscle guarding, and then okay, Dr. Sabai got the message. We will I'm going to show you some exercises for all these things, especially when the mobility is restricted and or when we need the strength in our shoulders. I'll briefly touch the acromioclavicular joint as well. I'll just leave the I'll show you the management of the frozen shoulder with some exercises. I'll briefly touch the acromioclavicular joint, the sprain of the acromioclavicular joint. It usually affects the athletes. It's very common in the athletes. Usually a fall on the shoulder causes the AC joint sprain. And the repetitive activities that I already mentioned, like swimmers, weightlifters, or the bodybuilders, they usually experience the AC joint sprain because the ligaments of the acromioclavicular joint are not very strong. So we see this. Depending on the type of the AC joint sprain, there are 6 types of the AC joint sprain. The type 1 and type 2 are treated conservatively with the modalities and the exercises. For the type 3, usually we recommend to see the doctor, and sometimes they need some surgical intervention. The most important thing is how to prevent the shoulder pain. So it depends on what you are doing, how much you need to use your shoulder. But it's good thing to take the steps to protect it. If you're working on a desk, make sure that you use an ergonomic chair and you keep your posture very good. Again, posture is is the key to the prevention and treatment of the shoulder joint. And you should be taking breaks at least once an hour. And if your job needs lifting, you should use a proper lifting technique. The lifting technique were told by Ramesh in the previous webinar, so I'm not gonna touch that. And if you're using your shoulder for raising or something heavy over your head, you should use a stool or a ladder instead of picking up something from there. So now I would like to go through some exercises. We'll stop sharing the screen and I'm gonna demonstrate some exercises. Dr. Saab, are you able to see me or
you need
hear
to
me?
turn your camera on.
Okay, I did that. I turned my camera on, but I believe it's not running.
No, I don't see you on the camera. So, not sure what's going on.
I have no idea, Dr. Saab, what is it?
Yeah, now we can see.
Okay, so depending on the condition, if we will start with the frozen shoulder first. If there is limitation in the shoulder joint, we should start with the exercises for the mobility of the shoulder. One of the exercises that I was talking about is the pendulum exercise. That's very effective and very useful for the condition. I'm going to demonstrate that to you quickly. So suppose this is my affected shoulder, and I'm going to lean on the unaffected shoulder. So I will use I can use either the chair or the bed or a stool like this. I'll use this. So we need to hang the shoulder down. Initially, we will not use any weight, but later on we can add some weight to the hand. We let the arm hang down, and then with moving our body, let us move the hand. So the shoulder moves forward and backward with the movement of our body, like this. So we move forward and backward, we move side to side, and then we make circles clockwise and anti-clockwise. So I would recommend this exercise for decreased mobility of the shoulder. It's very effective. It decreases the pain as well because it distracts the shoulder, the humerus from the shoulder joint, and that distraction causes some pain inhibition as well. That is one of the exercises that I would recommend. The second exercise, we can either use a stick, a wand, or I'll use a stick to show you. We will call them as active assisted exercises. So this is a very small one. I hope you guys will have a bigger one. We can use the broomstick for this exercise. Usually the flexion, the abduction and external rotation is limited in the frozen shoulder. So I'm going to show you how to do the abduction. We hold on to one end of the stick, and with the other hand, we hold the other end of the stick. We need to keep the elbow straight for the affected one. And then pushing, we keep the thumb up towards the ceiling as well. Pushing up with the stick, we move it as much as it goes within the pain-free range. And we do it starting with 10 repetitions, 2 sets at least twice a day. So this is a good exercise for increasing the abduction. Again, we will use this one for the flexion as well. You can hold on to the stick, and with the help of the unaffected hand, you can use it, lifting the arm all the way up. Again, it should be pain-free all the time. So initially, you will feel some pain at some point. I would recommend you to use it within the pain limit initially, and then once you are able to tolerate the pain, you can tolerate mild pain, because some pain is expected, right? But it should not be very intense pain. That was for the flexion. For the external rotation, which is very limited in the frozen shoulder, you can hold on to the stick with your elbows bent. Dr. Sab, are you able to see my video?
Yes, we are able to. Yeah.
Okay. So keeping your elbow bent, both elbows, holding on to the stick, and then with the unaffected hand, you move the stick away from your body like this. And then you come to the neutral position. And you do this 10 repetitions of 2 sets. It's good to do 2 or 3 times a day. And then to increase the internal rotation of the shoulder joint, we can do 2 things. One is we can either use this stick holding on from the top. So this is now my affected hand. I'm holding on to the lower end of the stick, and with the good hand, I'm pulling it up to increase the internal rotation. I'm going to hold it for 5 seconds, and then I will let it go down. Or you can use a towel. I'll show you how to use a towel as well. So we can use a towel for increasing the internal rotation range of motion. So you hold on to one end of the towel, and with the unaffected hand, you pull the towel up so that you regain the internal rotation. So these exercises are for the frozen shoulder. Is there any question so far?
No, it looks very good. It's a very interesting exercise, especially pendulum and stick. By the use of stick, we can do so many exercises. Simple.
Yeah,
exercises.
Okay.
Excellent.
Also, I'm going to show you another active assisted exercise using the wall. So if you do not have either the stick or the towel, you can still use the wall. Climbing your fingers up to increase. So when you're facing the wall, you are basically increasing the flexion, moving it up as long as you can move. Or when you face away from the wall and then you climb your fingers up, you are basically increasing the abduction over there. So these are to increase the mobility of the shoulder joint. Then once the mobility is regained or is better, then we move on to the strengthening exercises in the second phase. For the strengthening exercises, we always start with the isometric. Isometric is when you work on your muscles, but you do not move through the range. So basically, you are strengthening the muscles. You feel the contraction of the muscles, but it's not moving through the range. The first exercise for the isometric I would show you is the external rotation. So the external rotation is you keep the elbow bent by your side, and this is the movement that we will be doing. So this is called external rotation. To make it isometric, we need to hold the arm with the other hand. So this is providing the resistance, and it's not letting it move. So you are trying to move the hand outwards. You will feel a contraction here in the shoulder muscles, but it's not moving. and not causing any destruction on the tendons. So this is the external rotation. The other one is the opposite of it. It's called the internal rotation, that is towards your tummy. Again, you're using your other hand to restrict the mobility, but you are still contracting the muscles. So you are working on the internal rotator strength, but it's not causing any aggravation or any problem to the tendons. So that is the internal rotation. To work or to strengthen the flexors, you need you need to keep the elbow bent, and now this time you are providing resistance with the other hand to the front. You are moving it forward, and this hand is not letting it move forward like this. This is the flexion. So you should be feeling contraction. It should be pain-free, and you hold that contraction for about 5 seconds, and then you relax. All of these exercises should be pain-free, and we should hold them for about 5 seconds and do 10 repetitions of these exercises twice or thrice a day, or is convenient. The next one is the extension, isometric extension. You can either use your hand or you can use a wall to do the extension, like against the wall like that. Okay. These are the isometric exercises that usually we start for the strengthening. Once we get comfortable with the isometric exercises, then we start doing the dynamic exercises. I'll show you the dynamic exercises using, we will use the TheraBand. So make sure when you want to start using the TheraBand, there are different colors of the TheraBand that have different elasticity or different resistance. So we will start with either the red or the yellow one, because the resistance of these is not very much. So we will start with this and will gradually progress to the green, and then the gray, and at the end the black color. So I was talking about the external rotation and the internal rotation. For the external rotation, you hold on to the elastic band like this. You hold on to one end of the elastic band. So I'm working on this hand right now to strengthen the external rotators. So I'm holding on to the elastic band with my elbow bent at about 90 degrees, and I will not be abducting my arm at all. So it's a good idea to keep something, for example, a towel here, and do not let it drop like that. So you keep your arm by your side. Okay, so you hold on to the elastic band, and then you move your arm away from the midline and hold it for 3 seconds and come to the neutral position. This is the external rotation that we are working on. For the internal rotation, you need to put it around something. I will be putting it here. So are you able to see my hands now?
Yes.
Again, keeping your elbow bent and holding on to the elastic band and moving it towards the tummy, holding it there for the 3 to 5 seconds and letting it go very slow. So the backward movement of the arm should be very controlled, because this generates some tension in it. If we let it goes abruptly, and that may cause an injury again. Before doing these things, I will tell you guys about the scapular stabilizers first. So we need to have a good posture for all these exercises, and the good posture we can achieve by retracting the shoulder blades. So keeping your arms either straight or bent, doesn't matter, but you need to squeeze the shoulder blades like this, and then trying to put your shoulder blades into the back pockets. Are you able to see me, Dr.
Yes, we are able to.
So we need to retract the shoulder blades and then depress the shoulder blades like that. This is the optimal position for the shoulder exercises as well as for the postural correction. So again, posture is the key for healthy shoulders. We did the external internal rotations, and now we will be doing the flexion and the abduction. For the flexion, you can put it under the foot like that. So that's I'm stepping on it, and then keeping the arm on the side with my elbow straight, I'm lifting it to 90 degrees. So that is to strengthen the abductors like this. And then slowly and gradually lower the arm down. Again, we will start this with about 10 repetitions. 1 or 2 sets is convenient, but usually it should be good for 2 to 3 times a day. For the flexion and extension, we will again use the elastic band. I'm going to step on the elastic band. For the flexion, I need to keep it at the front and move my arm up, holding it for 5 seconds and lowering it down very slowly. That is to strengthen the flexor muscles or the muscles at the front. The opposite of this should be extension. So we ideally should put it around in the front and then move it backwards. But we can use the foot as well to do the extension exercise like this. So we have to take the arm behind our body, hold it there for 3 to 5 seconds and lower it down slowly. That is to strengthen the extensor muscles. We can do lots of exercises for the strength, but these are the ones that are very easy, and we can use a simple stretchy band or a TheraBand for these exercises. Another thing, I think we have a few more minutes, right?
Oh yeah, we have 8 minutes.
Okay. I think these are enough exercises for the strength and the mobility. I would love to have some questions if anyone has a question for me.
All right.
Is there any question?
Thank you, Sahab. It was a great demonstration, especially starting with anatomy and all the different conditions of shoulder and management as well. So I love this session of exercises portion. That was excellent. We have, there's a few questions. I would say, first thing is if you can tell us what are the exercises one should avoid not to do exercise for shoulder. Just in the gym, for our young audience, people who go to gym, they're doing exercise of the upper body, lower body, shoulder exercises. Are there any exercises which can be harmful?
Dr. Sab, technically there should be no exercise which is harmful for the shoulder. The only thing I would say is if there is any pathology in the shoulder, for example, if there is anterior instability, no exercise should be done with external rotation and abduction combined. So if you have weight in your hand and, for example, you are doing some bench presses or something like that, and your arm goes behind your body, that provokes the instability or that injures you more. So that should be avoided. Otherwise, if someone is healthy and has no problem with the shoulder joint, I believe these exercises or the exercises inside the gym are very helpful for strengthening the shoulder.
So basically, when you're doing bench press or sitting position, not to go behind your head, basically, or it can compromise.
If there is any instability, that is just an example. If there is, for example, anterior instability, then you need to or you have to avoid this movement so that the capsule, the anterior capsule is injured or lax. But once you do this movement, the humerus comes forward and it leaves the socket and it aggravates the problem.
Sure.
So this is just one example.
Excellent. So there is, I'm just reading some questions here. So there's a question from Dr. Maimuna Bhatt. If you can repeat all exercise in sequence, so is there any sequence for exercises, like in a routine for healthy shoulders? How do you start from whether you want to, like without any injury? I think that if I understand the question right, Dr. Maimuna, maybe let's see if we can ask her to put the question to you. Let me allow her to talk. Dr. Maimuna, can you?
Yeah.
Okay.
Hi. Thank
Hi,
you very
doctor.
much for the nice presentation. Yeah, just to have a recap of the exercises, maybe one time each exercise. So for the healthy shoulder, basically, like
Okay, for the
if
healthy.
we had no problem, just to repeat from the beginning that you started from the frozen shoulder, so that if someone has missed any movement, we can do just one exercise at a time. Yeah, once.
So, Dr. Saiba, the most important thing for doing the exercises is any exercise that we do, we should have our shoulder girdle warmed up before doing any exercises. So the warm up, that prepares the muscles for the exercise, that brings the blood, and it makes the muscle flexible for the exercises. If we are not warmed up and we do the exercises, there's a chance that we get an injury into the tendons as well. So if this is not the frozen shoulder that you said, if it's not the frozen shoulder, then is it okay to start with the bend, or do you want me to do all the exercises again?
We can start just with the band.
Sure. So basically there are 8 movements available at the shoulder joint. The one is flexion, then it is extension, abduction, adduction, external rotation, internal rotation, and then horizontal abduction and adduction, right? So we can use this bend for all these movements. We will start with the flexion first. So for the flexion, we can step on this thing. Are you able to see my foot there, doctor? So I'm just stepping on the
Yes, that's good.
The bend. And to do the flexion, we need to keep the elbow straight and lift the arm up against the resistance. Make sure the resistance is not too much. This bend is not very tight, but if there is another bend like green or the gray one, that is very tight. So make sure it's not very tight, not too loose, to offer you the resistance. So we move it up, hold it there for 5 seconds, and bring it down slowly. That is for the flexion. For the extension, we go again, we are stepping on this, make sure it doesn't prop up, and then move the arm backwards and hold it there for 3 to 5 seconds. For the abduction, still it's under my foot, and I'm moving it up in abduction and down. For the adduction, we need to put it somewhere like up there and bring it down towards the body. I can do that right here. Are you able to see me, doctor?
Yeah, that's good.
So we can bring it down towards the body, but unfortunately the cabinet is getting opened.
Okay.
Like this. For the external rotation, you can hold it in your both hands and you move your arm outwards against the resistance and bring it back. So that is external rotation. For the internal rotation, you put it around something and you move the arm inwards towards the tummy. But make sure for the external and internal rotation, the elbow should be bent about 90 degrees and it should not be abducted. And again, the primary key that I was talking about again and again is proper posture of the shoulder. So when you're doing the exercise, make sure that you retract your shoulder blades and depress them so that it does not affect your posture. Is there anything else, doctor, that I can talk about?
No, excellent. Thank you very much for repeating these exercises. Just a question for these TerraBands. That's first time I've heard about this TerraBand.
Okay.
So you said red has the least strength,
Yes.
right? Red, then
Yellow,
blue, green, red.
yellow and red least, followed by the green, followed by the gray. Sorry, the blue, the gray, and then black.
Excellent.
So black and gray are very tough.
So
and they are available anywhere, like at a sports check or any physiotherapy clinic.
Yeah, that was my next question. So that's great. So these things are very informative. Patients, we can, as family physician, it's the first time I'm hearing that we can use these things. So we can always tell our patients, as you know, it's really expensive to have physiotherapy done. People who don't have their coverage.
Dr. Zaid, Fiq, in case you want to know, these are available on Amazon. I'm not promoting
Amazon, but exactly.
I ordered some from Amazon, and they're really good and very useful. So people can order it from there if you want.
Exactly.
Excellent. Thank you, sir.
Thank you, doctor.
Very nice. I think that's about it. Excellent presentation, and definitely we'll have you for future sessions for MDI Active Living. Thank you very much, Raghusab. Thank you, Dr. Rahman, for starting the session. And MDI team would like to continue these sessions, and you are part of the team, and inshallah we'll have you for future presentations. Our next session will be on 5th of November by our kinesiology students. I'm not sure about the topic right now, but we'll announce it in a week time. Thank you, everybody.